That's automatic. All right, so we're unmuted, just so you know, so don't say anything inappropriate. Or if you do it on purpose. Great, thanks so much.
Yeah, no problem.
Hey, thanks, Kyle.
Yeah.
So we're good over there, and this other screen is
This is like,
talk of the season. And as it behooves the occasion, this important inaugural talk is being helmed by Dr. Deepak Bhatt, who is the director of the Mount Sinai Fuster Heart Hospital, and the Dr. Valentine
Dr.
Fuster
Kidwani.
Professor. Yes. Yes, Evan? Evan, can you hear me?
are you muted?
Can you guys hear me?
Yes.
Yeah. Yeah,
Oh.
we can hear you.
Okay.
Sorry, I'm in the wrong place.
You can, right? Good. Can you hear us though, Evan? Okay, thank you.
No, I don't think he can hear us.
I asked him and he said yes.
Oh, okay.
I can hear you guys. Everything
Okay,
sounds good.
Oh, good.
Okay. Okay, our inaugural talk is being given by Dr. Deepak Bhatt, who is the director of the Mount Sinai Fuster Heart Hospital and the Valentine Fuster Professor of Cardiology or Cardiovascular Medicine at the Icahn School of Medicine at Mount Sinai. After graduating as a valedictorian from the Boston Latin School, Dr. Bhatt obtained his science degree as a National Merit Scholar at MIT, his MD from Cornell, and MPH from Harvard, and an executive MBA from Oxford. He trained in internal medicine at the UPenn and cardiology at Cleveland Clinic. He completed fellowships in interventional cardiology and cerebral and peripheral vascular intervention, and served as the chief intervention fellow at Cleveland Clinic, where he spent many years as an interventional cardiologist, associate professor of medicine, and the director of the interventional cardiology fellowship, and many other administrative posts at Cleveland Clinic. He then served as the chief of cardiology at the VA Boston healthcare system and subsequently as executive director of the interventional cardiovascular programs at Brigham and Women's Hospital. He was a senior investigator in the TIMI study group and editor-in-chief of the Harvard Heart Letter. He later became a full professor of medicine at Harvard Medical School in 2012 and was selected by Brigham and Women's as the 2014 Eugene Brownwald Scholar. He received the Research Mentor Award from Brigham and Women's Hospital, Department of Medicine in 2016, and the Eugene Brownwald Teaching Award for Excellence in the Teaching of Clinical Cardiology from Brigham and Women's in 2017. He was the ACC's Distinguished Mentor Award in 2018, AHA's Distinguished Scientist Award in 2019, NLA's Honorary Lifetime Membership Award in 2021, and SCI's Master Designation in 2022. He has authored or co-authored over 2,000 publications and has been listed by the Web of Science Group as a highly cited researcher from 2014 to 2023. He's the editor of Cardiovascular Intervention, a companion to Brown-Wall's heart disease, and of OP's Cardiovascular Drugs, a companion to Brown-Wall's heart disease. He's one of the co-editors of Brown-Wall's heart disease, the seminal textbook. He has served as a senior associate editor for news and clinical trials for ACC and is the editor of the Journal of Invasive Cardiology. He was the PI for some very important cardiology trials, including Charisma, Crescendo, Cogent, Reduce It, Soloist, Scored, and Intrigue, and the co-PI of three very important trials, the three champion trials, the Stampede trial, the Savor Timmy 53, the Simplicity Hypertension 3, Themis PCI, and the REACH registry. In 2014, he was listed in the AHA/ASA Top Advances in Heart Disease and Stroke Research for his Stampede and Simplicity Hypertension 3 trials. And in 2018, Reduce It was listed and also named the top cardiology trial by New England Journal in 20. And again in 2021, the Soloist and Scored were listed by AHA. He is the inaugural chair of the AHA Get With the Guidelines Quality Oversight Committee and has served as trustee of the American College of Cardiology. It is my distinct honor to have here today Dr. Deepak Bhatt opening our academic year for the critical care group. Thank you, Dr. Bhatt.
Well, thank you very much for that kind introduction. Hopefully everyone on Zoom can hear me. If you can't, please signal somehow. It's wonderful to be starting off the academic year for the Critical Care Institute in terms of your Grand Round series. So I thought I'd start with something that would be hopefully useful to everyone in critical care, and that was pertaining to the optimal management of acute coronary syndromes in 2024. Before I get started, these are my disclosures, none of which are directly relevant to the topic today, and I might talk about things that end up being off-label or investigational with respect to either drugs or devices. So let me start a little bit with the basics in terms of acute coronary syndromes. Probably all of you are familiar with the fact that the coronary arteries are subject to plaque formation and plaque rupture. In particular, plaque rupture accounts for about 60% of acute coronary syndromes. ST segment elevation MI or non-ST segment elevation MI, typically a lipid-rich plaque with inflammatory cells on the inside, a thin fibrous cap, superimposed plaque rupture, and then thrombus formation, fibrin and platelet rich. And if it's occlusive, generally speaking, we believe that to cause an ST segment elevation MI, non-occlusive, a non-ST segment elevation MI. It used to be that we thought that was really the hypermajority of acute coronary syndromes. It is the majority, but it turns out a significant proportion and an increasing proportion of causes of ACS include plaque erosion, about 25% of ACS. This is a bit more common in women than men, but plaque rupture is the most common cause of ACS in both men and women, but in terms of ratios, plaque erosion is a little bit more common in women than men. And here, it's a similar sort of pathophysiology, but it has to do more with a denuded endothelial surface caused by local blood flow perturbation, and then formation of thrombus, in particular platelet-rich thrombus here, even more important in this setting than in the setting of plaque rupture as far as platelet aggregation. And about 5% or so of ACS are caused by calcifying nodules. This isn't a frequent cause, but it's oftentimes a tricky cause. Can be quite challenging to treat. And fortunately, there are techniques in the cath lab that can be helpful. I'll mention that a little bit later. Coronary spasm is also the cause of ACS in a low single-digit proportion of cases of ACS. It can occur with other sorts of etiologies as well. It can be multifocal, it can be multivessel, and it typically occurs in the presence of damaged endothelial cells. And I'll show some pictures later. Part of our understanding has evolved. Most of these folks do have atherosclerosis. It just may not be visible on an angiogram, but might be in the vessel wall. A rare cause of ACS is spontaneous dissection, about maybe 1 to 4%, where the vessel wall essentially unravels on itself. This is particularly common in young women presenting with a myocardial infarction, and then embolism, say from atrial fibrillation or left ventricular thrombus after a big anterior MI, endocarditis, etc. So these are some of the common and uncommon causes of ACS. There's also this entity of MI with non-obstructive coronary arteries, sometimes called MINOCA, that accounts for about 5 to 6% of ACS. Here are some images describing or showing plaque rupture as the cause of ACS in this patient with MINOCA, MI with non-obstructive coronary arteries. You can see a right coronary artery here. There's no obstructive lesion per se, mild to moderate lesion here in the distal right coronary artery. But what we see on intravascular imaging, OCT, optical coherence tomography, is a lipid-rich atheromatous plaque with a large necrotic core. So this provides some pathophysiologic insight in real time in vivo in terms of what the etiology of the ACS may have been in this patient, whereas 10, 20 years ago, we would have probably said that this patient had normal coronary arteries, but our evolution in understanding has evolved. Not that I'm saying that this sort of imaging needs to be done in every patient, but it can be useful if the etiology of a patient's presentation with suspected ACS is in question. Here's an example of a ruptured plaque with an empty cavity seen on OCT. So really nice high-resolution images. Hopefully those of you on Zoom are able to see this and where my arrow is pointing. Here's an example of plaque erosion as the underlying cause of an MI with non-obstructive coronary arteries. So you can see again a right coronary artery. What looks to be, I might have said, a calcified lesion right there, but what we see on the OCT is a red thrombus with an atheromatous plaque without apparent rupture. So this is plaque erosion or OCT evidence of plaque erosion. So what I would have said, oh, that's a big calcified nodule, actually ended up being thrombus. On the other hand, this area here, which really maybe has, I would have said, some mild calcium on OCT, turns out to have a rather large calcified nodule. So sometimes the intravascular imaging really provides information that is quite different from what we would have thought we would see on from the angiogram and interpreting it. Here's some multimodality imaging that can sometimes be useful when an MI occurs with non-obstructive coronary arteries. Imaging such as with MR or with CT can often be useful. This is a patient that had quote-unquote normal coronary arteries, but they definitely had an MI, rise and fall of cardiac biomarkers, good story, seemed like the real thing, but an angiogram that was essentially normal. But what we can see here is evidence of a septal myocardial infarction. And you can see on this non-invasively obtained angiogram that there is a patent LAD, but an occluded septal perforator, which on an invasive coronary angiogram, even with this knowledge and going back and looking at it, it wasn't evident. So this really shows the value in certain circumstances where the diagnosis is unknown to really nail it down. Obviously, there are cost implications if you were to do this in every patient, but putting that aside, it can be useful to nail down a diagnosis. Here's an example of postpartum spontaneous coronary artery dissection. Again, in young women, this is the most common cause of myocardial infarction, spontaneous coronary artery dissection, not necessarily just in the postpartum setting. And this is a 36-year-old woman presented with classic retrosternal chest discomfort about 2 months after labor. The ECG showed ST segment elevation in the anterior anterolateral leads. And what we see here is coronary artery dissection. This is another view of the left anterior descending artery. You really want to resist the temptation to treat these folks with stents. This is often the pressure, the momentum in the cath lab, but here you really want to treat them medically unless it's refractory chest pain with ongoing ST segment elevation or hemodynamic perturbation. And in this particular case, treated medically, a repeat angiogram was done. Don't necessarily need to do a repeat invasive angiogram, but one was done here 6 months later, where we see that the vessel has healed completely, just on medical therapy. In this case, dual antiplatelet therapy and a beta blocker, both of which are controversial in the treatment of scabbing, but that's what was done here. Here's another example of a rare cause of acute coronary syndromes. This is a patient with a left anterior descending artery in diastole on the left and systole on the right. So this is a myocardial bridge. And usually those don't cause ischemia, but every now and then they do, and in this case seem to be associated with the ACS. Here we've done some fractional flow reserve measurements. I'll come back to exactly what those are in a moment, but fractional flow measurements showing a diminishment of flow in the LAD with adenosine, and more often dobutamine is what you would use in this setting to bring out the myocardial contractility. And here the patient was treated with beta blocker with good effect, and there was no need for any procedure. It's very rare that you would ever stent these or unroof them with a surgical approach. So every now and then that does happen. And just in terms of what FFR is, that's a fractional flow reserve. So it's essentially looking at the ratio of the pressure distal to a stenosis and proximal to a stenosis. And if that value, the classic literature said, was 0.75 or less, that's a really significant lesion. In the contemporary era, we've sort of drifted up to saying 0.8 or less, so there's a little bit of a buffer in terms of not missing lesions that are potentially significant. There are other versions of this, things like the instantaneous wave-free ratio. There, the cutoff is 0.89 or less. But the idea is really looking at pressure proximal and distal and extrapolating what the flow probably would be. Here's an example of an FFR in a patient that had come in with an ACS. The red arrows document serial lesions. They're sometimes a little bit difficult to really figure out which one might be the culprit. But at any rate, an FFR was done here, very abnormal at 0.43, and the lesion was successfully stented with a repeat FFR of 0.93. So at any rate, sometimes this sort of technology can be useful in the cath lab to determine which lesions are really significant. Here's another example of ACS due to a somewhat unusual cause. This was a young man in his early 30s coming in with non-sustained ventricular tachycardia, sensation of palpitations, and ended up getting a invasive coronary angiogram because he had a large rise in his biomarkers associated with that arrhythmia. And what can be seen here is a severe stenosis in the mid-LAD that improves after nitroglycerin. So this is coronary spasm, a rare cause of ACS, but it does come up every now and then. And here in the right coronary artery, he also had some moderate atherosclerosis, as he did in the LAD. No severe lesion, but some underlying atherosclerosis at the site of that spasm. And here's a cardiac MRI on that same patient showing plaque in the vessel wall, both in the LAD and the right coronary artery. So very different from what we thought years ago, where we thought spasm was occurring in the setting of no atherosclerosis. In fact, it's occurring in the setting of atherosclerosis most often. Every now and then, you might find someone with trivial or no atherosclerosis, especially in the setting of cocaine use or things like that. But in general, there's some atheroma there if you look for it. These rare causes of ACS can occur in anybody, but they do tend to occur a little bit more commonly in the young, and therefore I've shown here an algorithm of what to do with folks with premature acute myocardial infarction. So the first step is myocardial assessment, and typically that involves coronary angiography as a first step, seeing if they've got obstructive or non-obstructive coronary artery disease. And it's useful, I think, to measure things like Lp(a). Here we measure Lp(a) pretty commonly, but not every place does. Exclude recreational drug use and that sort of thing. But otherwise, if it's obstructive CAD, the treatment's the same as for older patients. If it's non-obstructive coronary arteries, perhaps Minoka, that I alluded to before, it's important to evaluate and exclude SCAD, spontaneous coronary artery dissection, particularly in women, though it does occur in men as well, or occlusion of small branches, like I said, can be missed. If there's a suspected thrombus in the coronary artery, you might also want to look for some sort of regional wall motion abnormality on echo. At any rate, if the patient falls into this 10 to 20% sort of Minoka situation, still you want to think about drug use, including cocaine. You want to ask the patient, but better to test than just ask. So always, check the appropriate tests. In this case, urine metabolites. Most patients that come in after cocaine or amphetamine or other use will typically deny it. So I think there is value in testing. It can be useful to then do an OCT, and if there's plaque disruption of the sort I mentioned, well, then you've identified the pathology. And if there isn't any sort of plaque disruption, you might think about things like hypercoagulable states, coronary embolism. And in those circumstances, it might be useful to do things like a cardiac MR. And that can then help with the diagnosis of whether it is in fact a myocardial infarction, whether it's myocarditis, or whether it's just something else. And if it really looks like there's no obvious etiology, you could consider testing for spasm. A variety of ways of doing that, with things like acetylcholine. Now, everyone is aware of angioplasty and stenting. Sometimes for really calcified lesions or calcified nodules, this is true in ACS, but also non-ACS patients, it's necessary to do atherectomy. And I know those of you from the cardiology and interventional cardiology point of view see a lot of that here. We do more than probably any place in the country. But for the critical care folks, if you're not familiar with that, it's used for calcified lesions.
Thank you for shopping at CVS. Please remove all bagged items. Well, if you have your extra care card, please.
Oh, excellent. I'm glad someone's using the time well for online shopping. I'm a multitasker myself, so I can respect that. But please do mute your lines just so that folks can hear. So on fluoroscopy, without injecting any dye on panel B, you can see this where the arrows point to the calcium. So this is a heavily calcified vessel. And so an intravascular ultrasound is done. It shows an arc, a 270 out of 360 degree arc of calcium. Those are the sort of lesions sometimes it's hard to just throw a stent in, get good stent expansion. So in this particular case, we've done some road ablation of the mid-LAD and then went ahead and stented it as we typically do with a nice result. So, these are some of the different techniques that can be used in ACS or non-ACS patients. Sometimes bypass grafts cause ACS, and this is an example of that. This is a patient with a bypass graft to the right coronary artery. The yellow arrow points at a culprit lesion, very tight lesion. In this case, an embolic protection device called a filter wire is placed in the vein graft down below. Past where the lesion is, a stent is implanted, and hopefully any sort of debris that's in there gets captured by the filter. And as you can see from the yellow arrow, hopefully it projects. There's a bunch of atheromatous gook that is captured, fortunately not going downstream and including all the different vessels and microvasculature. So one of the causes of ACS. In terms of some new concepts in ACS, one is this concept of SMRFs. Probably those of you in critical care haven't heard of it. I don't know if everyone in cardiology has heard of it, but it really refers to standard modifiable risk factors and the absence of them. It really is what we're talking about. We like to think of patients with ACS as having risk factors like high cholesterol, high blood pressure, diabetes, smoking, some of the other things I mentioned. But sometimes there are these patients that show up without SMRFs. And, it's been debated, are these really real? Are there really patients that don't have risk factors? And I think it's a mixed bag. I think some of these patients, maybe half of them, really do have risk factors. That is, the LDL is 180, but nobody's been doing anything about it. So it's risk factors that haven't been identified or haven't been treated but exist. But the other half probably are folks that really don't have conventional risk factors. And maybe these are the people that have Lp(a) elevation or hsCRP or inflammation or other things that are accounting for their MIs. What is the course of patients with or without standard modifiable risk factors? It depends. Actually, literature is pretty controversial. This particular study that I'm showing shows that the patients with SMRFs have a survival probability that's a bit better than those that are SMRF-less, but other studies have sometimes shown the opposite. And I think it's because of the heterogeneity of this population of SMRF-less patients. That is, whether they're SMRF-less patients because they've got some unidentified, maybe therefore hard to treat risk factor because we don't know what it is, versus someone that actually has something that's pretty easy to treat. That is, they're actually a smoker, but it wasn't documented. No one had asked them. So if they were to stop smoking, probably their risk would be much less than somebody that has some unknown novel risk factor where we don't really have therapies to treat it at this point in time. Another consideration in the ACS patient is those that also develop heart failure. That's a double whammy. That's pretty bad. Patients that have certain risk factors like pre-existing LV dysfunction or diabetes, hypertension, CAD, female sex, elevated creatinine, age, of course, atrial fibrillation, tend to be at higher risk for developing heart failure. And if this happens, the mortality is increased pretty substantially. ACS patients do rather well these days, but if there's concomitant heart failure, it raises the risk of everything, all sorts of badness, including death, sudden cardiac death, future hospitalizations for heart failure pretty substantially. And the management there in terms of medicines includes beta blockers, ACE or ARB, MRAs, of course, revascularization, probably SGLT2 inhibitors as well, based on recent data. All right, well, let me go through now, having shown some cases of common and rare causes of ACS, what the overall diagnosis and management of ACS should be. So the first step is binning patients into whether ST segment elevation is or isn't present on the electrocardiogram. If it is present, then patients should be treated with antiplatelet and anticoagulant therapy. That's true with the non-STEMIs as well. And then catheterization labs, if they're available within 2 hours, well, that's the treatment of choice. Prompt coronary angiography and intervention in the vast majority of cases, unless it ends up being one of those Minoka cases and their medical therapy, risk factor control, et cetera, are warranted. If catheterization can't occur within 2 hours, an unusual circumstance in an urban city and center like New York, they're still in a, say, rural area in the US, in a remote region elsewhere in the world, you would want to treat with fibrinolytic therapy, such as alteplase, reteplase, or tenecteplase. Streptokinase, almost never, unless cost was an incredible consideration. There's still a few places in the world where streptokinase is used. Even in those circumstances where there's lytic, transfer for percutaneous coronary intervention should occur within 24 hours or so. And then coronary angiography should be performed, and if there's still a residual lesion, that should be treated most often with a stent. Now, in the case of non-ST segment elevation ACS, that initial medical therapy is similar, as I said, but here biomarkers are particularly important. And now high sensitivity troponin is the standard of care, getting rolled out throughout the world, ideally within the first 3 hours or so. And if it's elevated, well, then a non-ST segment elevation MI is diagnosed. And if it isn't, then unstable angina is diagnosed. If it's an NSTEMI, those patients should also go to the cath lab within 24 to 48 hours or so. If they're stable, and if they're unstable, then they should go right away. And with unstable angina, if there are high-risk features that are present, by that I mean heart failure, ECG changes, ongoing chest discomfort, or hemodynamic instability, well, then those patients should also go onto the cath lab. If none of those features are present, then medical therapy and risk factor control is reasonable. Some sort of non-invasive evaluation should be performed. Historically, that's been stress testing. These days, it's more often computed tomography, angiography, or CT angio. And if those tests are abnormal, well, then the patient should still go on to cath. And if they're not abnormal, then it would still be continued risk factor control and medical therapy. I'll just say a little word about STEMI because this has changed in the past decade or two in terms of the treatment of it. So if an acute STEMI is diagnosed in the field, really the goal should be to go to the nearest hospital capable of PCI. If such a hospital is there, hopefully that hospital is part of the STEMI network. And if that's not the case, well then full dose fibrinolytic should be given. And if the patient is 75 years of age or older, at this point in time, I'd say a half-dose lytic should be given to decrease the intracranial hemorrhage risk, and then the patient brought on to the cath lab anyway. And if the patient, again, is in a place where you just can't have a STEMI network because of the economic situation there, you would just start off with lytics and not go through this algorithm. In terms of the timing of PCI, stable angina not really relevant to this talk. There you typically would treat medically, and the timing of PCI is not so important. For NSTEMI, about half the patients end up getting treated with PCI. The exact proportion depends on where you are in the country and world, but about half get treated with PCI, about 10 to 20% or so with CABG, and the rest medically if you look at all comers with STEMI and unstable angina. And as I mentioned, the window for that's about 24 to 48 hours. Ideally, I'd say within 24 hours, but if it's Saturday night, you don't want to drag in Dr. Moreno if the patient's totally stable. But there are benefits to going early in terms of reducing hospital utilization, bed utilization costs, potentially reducing bleeding risk by not exposing the patient to potent intravenous antithrombotics for a long time, but in general, okay to wait till Monday morning. And if it's a STEMI, as I mentioned there, in general, there's an occluded artery, so you want to go quickly, ideally, within 60 minutes, but a window of 90 to 120 minutes from time of first contact to intervention is probably acceptable. And once more, while this would rarely come up in New York, other than maybe in a blizzard or a pandemic or circumstances where you can't go to the cath lab quickly or don't want to, just don't forget about lytics. And for cardiology fellows, certainly don't forget about lytics on the boards. All right, so the best treatment for STEMI is primary PCI, but should you just go after the culprit lesion or should you go after all the lesions that are angiographically significant? This has been a point of debate for a number of years. Do you just go after, for example, here the distal right, or do you treat the circumflex as well, as was done in this case? I think at this point in time, the debate of that point has been settled for the most part. There's some contradictory information in trials, but overall, I say that the most rigorously done trials support complete revascularization, as in the complete trial, where if one looks at CV death or new myocardial infarction, a significant reduction both in relative and absolute terms with the complete revascularization in blue, culprit only in red, a significant reduction with complete revascularization, relatively low number needed to treat there. So in general, barring contraindications and using common sense, if the patient has multiple lesions, best to treat all of them. If one looks at CV death, MI, or ischemia-driven revascularization, well, then the degrees of benefit are even larger, cutting the rate of this endpoint basically in half. Interesting, though, if you're looking at harder endpoints like death or MI, and it's really spontaneous MI driving this difference, it's with longer-term follow-up that the curves diverge. So this is a benefit. We used to think, oh, this is a benefit that accrues over the next few days. And of course, there's always some patient you'll encounter where they have a recurrent ischemic event from a non-culprit lesion in the days after presentation. But most of the benefit here is accruing months and years after the procedure by treating plaques that are presumably unstable, even if they didn't cause PMI the day of that initial presentation. Here's some other trials looking at when exactly to do that complete revascularization. That is, should you complete it on the table? They come in with a prox-LAD infarct. You open that up, of course. Should you treat the mid-RCA right during that procedure? Should you do it later in the hospitalization? Should you bring them back a week or two later? Should you bring them back a month or more later? That's a very common practice in private practice, for example. It sort of maximizes a number of economic factors. So there are a number of ways of skinning this cat. The way that MultiStars did it was actually immediate. So during that index procedure versus staged. And they found a significant benefit of this. Now, the way this trial has been interpreted in the US, and certainly I've interpreted this way, mostly for the sake of comfort, is that the immediate means during the procedure or during that index hospitalization. And I think that's probably fine to do. I'm not sure it's necessarily a good idea if it's midnight on Saturday to chase lesions that are non-culprit lesions, but probably want to do it before the patient's discharged. Don't want to use common sense, because if the creatinine is 3, that's not a time to just start doing random non-culprit intervention. So that's the MultiStars trial, further supporting the complete revascularization and suggesting the sooner you do it, the better. This is the FIRE trial, also looking at culprit only versus complete revascularization, finding benefit across a variety of different ischemic endpoints for complete revascularization. But this trial examined specifically those 75 years of age or older, and also examined end-STEMI patients. Most of these culprit versus complete randomized trials have looked at STEMI patients. This one actually also looked at end-STEMI and finds benefit of the strategy of complete revascularization in these older patients, and seemingly finding benefit in both STEMI and end-STEMI, but realizing that the subgroup of end-STEMI patients is modest in size. Interestingly, if one looks at the secondary endpoints here, even all-cause death and cardiovascular death had p-values less than 0.05. New England Journal doesn't allow you to show them, but these are, in my opinion, statistically significant findings. So it does argue in appropriately selected patients to go ahead with a complete revascularization, even in the older ones. But once more, have to use common sense, some data from the ESC, for example, casting a little doubt on this approach. But you really just have to see, is the patient, very frail, they have a limited lifespan, is it a nursing home patient? I mean, there, again, use common sense. Well, if complete revascularization is good in a patient coming with STEMI, maybe even NSTEMI, what about a shock patient? It should be even better, right? If something works, it should work even better in a sick patient. That's what we thought for years. When patients came in with shock, we would definitely open up every lesion during that index procedure. But sometimes you end up being wrong following intuition, and sometimes better to actually do the randomized trial, as in culprit shock, where the rate of death or renal replacement was actually significantly higher with a multivessel approach versus just treating the culprit lesion only. So a bit counterintuitive, but even death was going in the wrong direction with a p-value of 0.03, as was the need for renal replacement therapy. So in general now, the teaching is if someone comes in, prox LAD, they're in shock, open up that prox LAD as quickly as you can, but certainly don't go after CTOs, complex calcified lesions in the right and the circ. But we used to think, oh, there might be some ischemia in a distance, but for right now, I would default to these data. Doesn't mean you can't bring them back in the days that are ensuing. If they continue to do poorly, they're in the unit. Dr. Gadwani saying, what are we going to do here? This patient's spiraling. It might be reasonable to bring the patient back, realizing that those sorts of procedures do have a high mortality and high complication rate. Some had said, well, maybe the reason things didn't work so well is you needed mechanical support to be used just more early, more aggressively. But at least to date, that's been a bit of a mixed bag. This is the ECLS shock trial, and finding actually, maybe I'll say surprisingly, no benefit in shock patients with ECMO. So even though I'm a believer, and I know folks here are a believer, this randomized trial actually didn't show any benefit. Well, this trial came out, the danger shock trial, a bit more recently, and this examined patients in shock as well, but now getting the Impella. And what was found, as published in the New England Journal of Medicine, was a lower rate of mortality. That was the primary endpoint. Also a lower rate of a bunch of other badness, things like a heart transplant and escalation of therapy and so forth. Hazard ratios of about 0.72, 0.74, both statistically significant. So, if you're a believer, this is, the best thing since sliced bread. It confirms that, Impella is saving lives. If you're a skeptic, you could just look at this and say, well, it's actually a modest number of patients you can see in each arm, about 170 in each arm. And probably if 3 or so deaths were moved from here to here, it would lose statistical significance. So this is, as we say in the world of clinical trials, actually a fragile result, statistically speaking. So does it reduce mortality? I would bet if this experiment were repeated, the p-value wouldn't be significant again. Might be 0.07, 0.09, 0.12. So where does this leave us? I don't know. Like I said, I think it confirms whatever practice you really want to do. If you're a believer in mechanical support in this setting, it certainly provides a justification to do it. And if you were skeptical, well, then maybe you should remain skeptical. Here is the subgroup analysis of the trial. Again, there's just 170 patients in each arm, so it's not really powered for subgroup analysis in any meaningful way. And in general, though, one could still say there's a consistency of benefit. Maybe if you had single vessel disease here, there was no benefit, but if you had multi-vessel disease, there was benefit. I guess that makes intuitive sense. If you just had a prox LAD and open it up, probably the patient's going to do okay if you got to them soon enough. The other subgroup, though, that got a lot of attention was this one here, where in women, the hazard ratio is right at 1, whereas in men, the hazard ratio is 0.66. So is this a real finding? Is it a chance finding? I don't know, but it does make one pause a little bit about whether the results apply to women. Although, as I said, one could pause about whether it applies to men because the p-value is rather fragile for mortality. But why not do it? Well, cost would be one reason, but we don't really care about cost in the US, so what other reason might you not just apply these? Well, it's shown here on this table. It's just the rate of adverse events. Just look at how high the rate of adverse events is here in terms of effect sizes, a 4 to 5-fold increase in safety endpoints, a doubling of moderate or severe bleeding, a quintupling of limb ischemia, renal replacement therapy being doubled. I've got to say, the common teaching had been that putting in mechanical support, especially during complex PCI, reduced renal injury. This is actually in a randomized trial showing the opposite. So those observations before of maybe less renal injury with Impella, probably spurious. It's probably that the healthier sick patients got the Impella and therefore it looked like their kidney function was preserved or getting better, but it's just that they were better substrate patients, the hazards of observational research. So here it actually is increasing the risk of renal complication, the risk of stroke about double. The rates are low, but still about a doubling of the rate of stroke. Some caution, and sepsis as well with positive blood cultures increase. But I'm not saying anything from the trial that any of you haven't seen every day, right? You throw in enough Impellas, you'll see a bunch of complications and really bad ones. So what do I ultimately think? I don't know that I say every patient should get one, but certainly in patients where you've exhausted other options, really don't think there's much maneuvering room with pharmacotherapy. I think it's a reasonable thing to continue to do, as most places, including here, have been doing. There's still some ongoing trials looking at different mechanical support, unloading before primary PCI and so forth. So, there'll be more data coming. But probably not a lot more high quality data coming, to be honest, because there was one planned trial of Impella where, the funder said, why roll the dice again? So they canceled the trial pretty much, is what I hear. So it's unfortunate, but maybe there will be other investigator initiated trials. So I've gone through a lot of different topics about ACS and the early diagnosis and management, but it's important to realize, as this nice figure from the ESC guideline shows, that it's all a continuum. Ideally, you want to get to patients before they develop ACS. And for those of you that are coming to my cardiology grand rounds, first of all, I apologize, some of it will be a repeat here, but part of it's going to be talking about how to prevent this first ACS, not just how to treat the ACS, but then how to treat the patient after ACS to prevent this recurrent ACS up here and alter the trajectory of this patient. So hopefully this line isn't going up so steeply, but hopefully reduces them to the blue line or ideally even the green line with appropriate medical therapy and where indicated revascularization. The final point I'm going to just make very briefly is that there are some chest pain guidelines. I talked specifically about ACS, but that's part of a larger universe of chest pain. And these guidelines, for the sake of time, I'm not going to go through everything about them, but there's a lot of good stuff in there that deals with both acute and stable chest pain, talks about testing, and talks about preventive therapies and some novel imaging approaches. By that, I mean CT angio. And sort of upgrades its utility in the evaluation of chest pain, including the subset with low-risk ACS. Also, some things I'll mention here, there's a lot about evaluating chest pain in women, discussion of microvascular disease, a discussion of MINOCA and ischemia with non-obstructive CAD, some things like moving away from calling chest pain atypical as a descriptor, and lots of other good stuff. And the good thing about these guidelines is they're very color-coded, especially for those of you, if you're in cardiology, I think you really should read them. If you're in critical care, probably you don't want to take the time to read the whole thing, but you could just look at the tables and the figures, and there are a lot of nice color-coded tables and figures emphasizing things like chest pain means more than pain in the chest. It can be other symptoms. Endorsing the use of high-sensitivity troponins around the world. I know that sometimes the high-sensitivity troponin is the bane of the cardiology fellow's existence, but the guidelines do recommend it, and I think for the most part, in appropriate clinical context, the data support it. The E of chest pain stands for, seek early care. The S is shared decision-making with the patient, obviously not for things like a STEMI, but for low-risk ACS, unstable angina. It's reasonable to consider non-invasive testing versus more aggressive invasive testing. And so on and so forth. So I'd say even if you're in critical care and super busy, as I know you all are, probably worthwhile to at least look at the tables and figures in this document that encapsulates all the different causes of chest pain, all the different diagnostic modalities, and importantly, all the treatment modalities. Well, thank you very much for your attention. Happy to take any questions from anyone in the live audience or on Zoom. I'm not sure if I can, how I access the people on Zoom, but maybe if, as we're waiting for that, anyone in the room have any questions about anything that I covered?
Hey, Dr. Bhatt, thank you so much for that wonderful grand rounds. So one question I had is, and I know that we've spoken about this on when we were in rounds together, was how do you see these non-invasive testing modalities expanding, especially both in the ICU and for outpatient workup of chest pain, as compared to when patients are going to need to go to the lab?
It's a great question, and let me say I really enjoyed and learned a lot working with you in the CCU. Thank you for that. I think in the future, CT angio is really going to take off. In fact, it's already taken off, but I think that will continue, certainly in the evaluation of stable coronary artery disease, but even in the sort of triaging of low and medium risk ACS. I mean, if someone comes with a STEMI, I don't think people are going to do a CT angio under normal circumstances. The only time I've ever done that was during the pandemic, where we were trying to keep our nurses and techs out of the cath lab just so people wouldn't get exposed potentially to COVID very early on. There we were doing some CT angios when we were thinking, is this really a STEMI? Is this maybe just pericarditis or myopericarditis or some other mimic, a Takotsubo's or something. So, there were circumstances there we were doing, but in general STEMI, those folks just go to the cath lab. For NSTEMI, if it's a clear-cut case, clear elevation in the troponins, good story, especially with, ECG abnormalities that are present in dynamic, there I'm not sure getting the CT angio would help. But in cases of a patient where the troponin's positive, but they're sitting there, they're totally pain-free now, seems kind of low risk, low level troponin elevation, those sorts of cases, I think getting a CT angio is not an unreasonable thing to do, especially in the patients where we used to, in that circumstance, get a stress test on them prior to discharge from the emergency department or from the chest pain unit. So I think in that circumstance, there can be value, an increasing value. And as you may know, now you can add to the CT an FFR to the test, so that gives you some sense of whether they're flow-limiting stenoses or not. If they're not, it doesn't mean it's not an ACS. Hopefully I made that point clearly, but it means you may not want to stent them or bypass them if there aren't really significant lesions. Now, having said that, no non-invasive test is perfect. Everyone here that's an interventionalist is cath patients who've had a CT where the FFR is positive and you cath them and it's not repeated on invasive FFR testing, and the opposite. Where the FFR is positive and then you go ahead and there's just nothing there in the cath lab that is hemodynamically significant. So not perfect, but can be useful in sort of integrating the data. As well as FFR, there's also now the ability with CT, a couple of different vendors, to characterize plaque. And I think there can be utility in that as well, and just trying to determine, is this an ACS, isn't it an ACS? We need more evidence, really, how to use some of that information. I'll touch upon that, in my grand rounds to the cardiology folks sometime in the next couple of weeks. But just to let you know, there's a lot going on in terms of research for a CT and making it even more prognostic, maybe even using it to titrate the intensity of medical therapy. So such trials are ongoing both in the US and in Europe. So bottom line, we're going to see a lot more of it.
One of the nice things I found with using it in the emergency room is we used to do like what we called a triple rule out, where you could rule out most of the dissections, major PEs, and ACS in one study, and which made it really nice for a chest pain workup and negative discharge. So I think it's really exciting. Thank you.
Oh yeah, no, I think the triple rollout's really exciting. That does depend a little bit on your radiologist and where you are. I mean, some radiologists aren't totally happy with the gating to do all three things. That is, they'll say, if you really want me to rule out, coronary artery disease, then it's got to be a separate study from one, that's ruling out dissections or PE. But on the other hand, if you're looking for left main or, really prox 3 vessel disease, then you can probably do a triple rule out with just one study. But if you're looking for more subtle things, lesions that are more mid or distal. Again, it depends. Not every place feels totally comfortable with it, but I think that technology will evolve too and get better as it has. I mean, the radiation doses, the resolution of CTs really improved. Yes.
What's the role of microvascular disease in the evaluation of chest pain, especially in the context of people with diabetes or maybe female gender and this whole inoka thing?
It's a great question. We don't really have we have a lot of data, but it's all observational data. So if you have microvascular disease, that's bad. It can definitely cause symptoms. There's a proportion of patients where we used to say, get out of here, it's in your head, your coronary angiogram's clean, when in fact, they really do have microvascular disease and chest pain. A proportion of patients that we used to say were false positives on their ECG treadmill, where they have ST segment changes. No, the ST segment changes are real, they just don't have epicardial lesions, they just have microvascular disease. So it's real. At a minimum, you want to treat it intensively with medical therapy, LDL lowering therapy, and so forth. So you don't want to just blow it off, at least with respect to risk factor modification. You want to be aggressive. It can be useful sometimes too, just to tell the patient, yeah, we believe you, it's real. This is the cause. We may not have great therapies in terms of symptomatic relief, but sometimes, just a good medical therapy, good blood pressure control, nitrates, long-acting calcium channel blockers, and some of those patients will help. Sometimes, just getting them into cardiac rehab and just, ramping up the level of physical activity and exercise over time, can help once they have the reassurance of knowing that there's not, an ulcerated 90% prox LAD, even if there's some degree of angina, hopefully then they can sort of ramp up the degree of exercise they have. Diet can be useful, I think, plant-based diet, in addition to LDL lowering with pharmacotherapy. But Dr. Moreno, any other thoughts about microvascular disease? Some of the folks here do a lot of testing for it. Dr. Sweeney, I know, does a lot of testing for it.
It's especially useful in females that has recurrent chest pains and has been, shopping around or seeing several doctors, and they had a cath, it was negative. So we do a protocol with acetylcholine. First, we have to eliminate the calcium channel blockers at least 48 hours before. We initially we didn't do radials because of the spasm, but now we're doing it with radials. And then we go with acetylcholine at doses of 20, 100, and sometimes 200. We take a special attention for the 12 lead EKG, and we evaluate changes as well as symptoms during the injection of the acetylcholine. Acetylcholine should induce vasodilation because it's induced muscarinic receptor cyclic GMP release of nitric oxide. But in these patients, they do the opposite. So they do a spasm. It's frequently to see arrhythmias and AV block in the last dose with the high doses. And then we move on and measure the index for microvascular resistance with the wire. And we initially see the velocity with testing with saline, and then we use the adenosine to eliminate the microvascular resistance with the adenosine. And then we calculate the velocity, and we see this index. If it is greater than 25, it's abnormal. And there is evolving data with trials now, most of them run by Yale and also by NYU, in which specific therapy in classification helps a lot. Quality of life. Events are actually high in this population. 5 years events are not, like used to say, syndrome X is benign. Data from Julio Panza in the old days of the NIH show very nice. For this data is changed. So it helps a lot to classify the disease, to reassure the patient, and most importantly, to follow them and see their relief. I have a series of patients in my practice in which they're very happy that finally somebody said, yeah, you have something and address it. So
yeah, I think there's a lot of practical benefits there. I mean, it'd be nice, I gotta at least put on my trust hat a little bit, if there were more randomized data showing that approach actually improves heart outcomes. There's no such data. But if it turns out in such rigorous study, it improves quality of life and isn't increasing complications or increasing cost excessively, seems like a good complement. I mean, some places do a lot of this, the Barbara Streisand Center at Cedars-Sinai, for example, in the Women's Heart Center, they do a ton of this type of invasive testing to evaluate patients. So, you always have to be a little cautious, right? Because if you do enough invasive procedures, even in the best of hands, every now and then, coronary artery will get dissected or a little embolism or something happens. So I have to be really cautious. Marcia, you had a question. I saw your hand before.
Yeah, for the N70 trial that you showed, do you think the outcomes would have been different if they looked at younger populations, other like younger than what's cut off with 76?
Yeah, that's a great question in terms of complete revascularization.
Because if you're younger, you'd assume that the disease is only going to progress at the time, so it might have interest now.
Yeah, I could argue it either way. I mean, older patients higher ischemic risk, so they get more benefit from the strategy. Or, if they're old enough and frail enough, they're not going to get any benefit. So it could go either way. But my sense is, looking at the observational data in particular, really does support the concept of complete revascularization. If you go back in time to the large cardiovascular database, for example, there in non-randomized observational analysis, it really does support the completeness of revascularization. I don't mean just in ACS, even in a non-ACS setting, does seem to provide benefit in high-risk patients. But, in terms of randomized clinical trials, there's not as much data in terms of complete revascularization. There's a lot of observational and even propensity-adjusted observational analyses, and most of them show benefit to the complete revascularization strategy. So I guess most surgeons and interventionists, their feeling, their bias is towards complete revascularization. And if one looks at the data that exists, I think it does support it. But it'd be nice to have more randomized data that really show that completeness of revascularization helps in NSTEMI. There's a practical point to it, though. You can't always know what the culprit is in NSTEMI. Someone comes in with a STEMI, you almost always know, prox, RCA, and that's the culprit. Maybe 1% of infarcts in STEMI have a dual infarct where there are actually two occluded vessels. It's pretty rare, but it does occur. With NSTEMI, sometimes, it's obvious there's a circ, hazy, 99% lesion. It's not really even an NSTEMI, it's really a circ STEMI, but it's manifesting on the 12 lead as an NSTEMI, but it's really an occluded circ. So putting aside the occluded circs and large diags that are really STEMIs, but looking like an NSTEMI on the ECG, for the rail NSTEMIs where it's not an occluded vessel, sometimes it's ambiguous. You can't always tell from the ECG or the echo, what the culprit is. And there, I think, in particular, complete revascularization is a good idea because you might have missed what the lesion is. That is, you might go after the tightest lesion, as angiographers like to do. They might go after the 90% prox LAD lesion, thinking that's what causes NSTEMI, but it might actually be the hazy mid 70% circ. So my bias as well is complete revascularization if it can be done safely in terms of NSTEMI. Any other questions from any of the room?
Excellent. Thank you so
Yes.
much.
Well, thank you. Thank you to those of you on Zoom as well.
So we have 3